Welcome to Longevity by Design, a podcast designed to give individuals access to the leading scientific information in the field of longevity. The ability to add years to your life and life to your years needs no opinion. Join us as we ask science to take the wheel. In each episode, Dr. Gil Blander joins a co-host and an industry expert in the field of longevity, shining a light and getting the answers to the key question: how can we live a longer, healthier life?
Hello, I am Ashley Reaver, and I'm joined by Dr. Gil Blander. Welcome to Longevity by Design, How to Live a Longer, Healthier Life. We're produced by Inside Tracker, your science-based guide to optimizing your body from the inside out. Our guest today is Dr. Ronald Krauss. Dr. Krauss is a senior scientist at Children's Hospital Oakland Research Institute, a professor of medicine at UCSF, and adjunct professor of nutritional sciences at UC Berkeley. Dr. Krauss's research aims to understand how to best prevent cardiovascular disease through early detection and management of its major risk factors, most notably elevated levels of blood cholesterol and lipoproteins. He has published over 450 research articles and reviews on metabolic, genetic, dietary, and drug effects on plasma lipoproteins and the risk of coronary artery disease, and has been cited over 100,000 times, which is amazing. Thank you so much for being here with us today.
Well, it's a pleasure.
So, Ronald, as Ashley said, it's a great pleasure for us to have you. And we heard so much about you. But we'd like to start with the beginning. So can you tell us a bit about your background and how have you decided to become a scientist?
Oh, boy. Okay. Well, that goes way back. I've really been on the science track almost as long as I can remember. I had a strong family history of heart disease and became very interested in prevention really through my own experience, and evolved through a series of experiences and educational activities. I was trained as an MD and did my clinical training and metabolic work. But for quite some time now, I've been deeply involved on the research side, focusing, as was mentioned, on abnormalities of cholesterol, lipids, and lipoproteins that predispose to heart disease. And that really came about initially through an interest in nutrition. I've been always interested in dietary effects on heart disease and have spent a lot of time in that arena. I was chairman of the American Heart Association Nutrition Committee for a number of years and have been involved with making dietary recommendations. But this work has been colored by my findings related to dietary effects that have led me into some new research directions, and doing both laboratory research and seeing patients in my clinic, been able to make this a translation from some of the research findings into clinical practice, and been trying to advocate approaches that can take advantage of the information that we're gathering to improve overall cardiovascular health.
Awesome. And maybe that's a great place to start. Overall cardiovascular disease, in particular atherosclerosis. Can you explain to the audience, in case they're not aware of what atherosclerosis is and what is the highest risk factor for developing that as well as overall heart disease?
Well, atherosclerosis is a condition actually that begins in childhood. It involves the formation of plaques, cholesterol-containing deposits. The arteries, we're particularly concerned when that occurs in the heart and the brain. It can cause heart attacks and strokes when it progresses. And we know that there's various stages along the way that we can retard or even reverse that process and reduce the amount of cholesterol in plaques. That's really the goal. I think a much of the field of cardiovascular prevention is trying to prevent the progression of plaques, because when they become more advanced, they can acquire inflammatory properties and lead to clots in both the heart and the brain. And that's what we want to avoid, because getting a heart attack and stroke is something that can be very debilitating or, of course, fatal. And we know that the factors that are involved are age is one thing, because as we age, we all of us to some degree develop some degree of plaques, but for the most part, they're not serious until they are advanced. And what causes the more advanced plaque is high levels of cholesterol in the blood, particularly forms of low-density lipoproteins or LDL that deposit much of that cholesterol in the plaque. But it can also be aggravated by many other factors. Smoking, obviously, is something we want to avoid. That can damage the arteries by mechanisms that involve oxidation. And it's oxidation of the cholesterol in the plaque that can really lead to the more serious consequences. Diabetes is another factor, what we call prediabetes. That is just mild abnormalities, glucose and insulin metabolism can predispose to plaque formation. High blood pressure is an important risk factor that we also want to manage. Family history is really very relevant to the work that I've been involved with because there are genetic factors that we are now tracking down and have been tracking down. Promote those cholesterol profile abnormalities as well as directly impact on the health of the arteries. And so when there's a strong family history of heart disease, we look very carefully for those factors. Diet, as I mentioned, is important. It affects many of these same factors. Cholesterol, glucose levels, and blood pressure can all be affected by diet. So we're looking carefully at ways that we can modify the diet. And that often involves individual approaches that not everyone requires the same dietary approach to manage their particular profile. So one thing that is really key, and it involves my clinical work, is looking at individual, because there's a lot of individual variability in all of these factors. And when it comes to trying to manage heart disease risk, one has to look across the board and try to take approaches that optimize as much as possible all these factors. And of course, when there's strong genetic abnormalities, they may not respond to diet. And we, of course, have a range of drugs. Fortunately, as a clinician, I can take advantage in my practice of some very powerful treatments, statin drugs being the main one, that can retard plaque development and improve overall prognosis for heart disease risk.
So can you describe the metabolism or the process of plasma lipoprotein metabolism and how the lipoprotein are related to atherosclerosis?
Yeah, sure. That's the area that I've been most deeply involved with my own research. There's a lot of complexity in these pathways, but let me just try to focus on the main ones that really are most relevant to plaque formation. It starts in the liver. The liver is the factory that does many things, including the synthesis of lipids, cholesterol, and triglycerides in particular. And when there's a lot of that going on in the liver can package these lipids and particles. In fact, that happens as a normal process that we all undergo. The production of these particles starts, for the most part, as what's called very low-density lipoproteins, VLDL, which contain both triglyceride and cholesterol, and a protein called apoprotein B, or ApoB, that is the main structural component of these VLDL particles. So that's what the liver secretes. And the process of metabolism, blood, the VLDL undergo many changes, starting with lipolysis, that is the breakdown of triglyceride in the VLDL particles, which then delivers components, particularly fatty acids, which are main chemical component of triglycerides. These fatty acids are released and are used by the body for energy in muscle tissue, for example, in the brain, but are also stored as excess triglyceride and fat tissue. So that process, which is mediated by VLDL, leads to the formation of products of this triglyceride breakdown, which products are called remnant lipoproteins, partially degraded VLDL, which can circulate. And here we start to develop properties that can become particularly damaging to the arteries. Remnants can be hazardous. So if there's excess VLDL secreted, if there's too much lipid metabolism going on in the liver, too much of the VLDL remnants, that's the first step that we look at as a mechanism for atherosclerosis development. But that progresses further. So these remnant particles are broken down further by lipases and they undergo various transformations, leading to the production of LDL, low-density lipoproteins, which are the major form of lipoproteins that carry cholesterol in the blood. When we talk about LDL cholesterol, which is a major clinical test that's used to identify high risk in individuals and also sets the standards for our guidelines for lipid management, which are aimed at lowering LDL cholesterol, that reflects the cholesterol content of these LDL particles. But it's the particles themselves, it's the whole package that delivers cholesterol and other lipids into the artery wall. And that's a major mechanism, again, resulting from VLDL breakdown, production of LDL that can lead to elevated LDL in the blood. Now, there's some important modifications of that process that I'll go into because I feel it deserves attention and is often not well understood, even by clinicians who deal in this area. And that is that depending on the amount of triglyceride that's being secreted, the form of LDL particles can differ. So there are different forms of LDL that vary in their composition and also in their size, such that the larger LDL particles that can circulate a healthy individual are formed when triglyceride levels are relatively low. So if you have a low triglyceride level, it tends to lead to larger LDL particles. And we've shown that levels of larger LDL particles, even though they have cholesterol in them, do not appear to be particularly hazardous to the artery. Patients who have isolated elevations of large LDL and are otherwise healthy do not often appear to be at high heart disease risk. But when triglyceride levels are increased, the VLDL particles are now triglyceride enriched, and those forms of VLDL lead to a second major type of LDL, which is a smaller LDL particle. And these smaller LDL particles that can be formed under these conditions are particularly damaging to the artery. So the important thing here is that there's really a constellation of factors that come into play in many patients now, because we are learning that the large VLDL to small LDL axis is heavily related to body weight. People who have excess body fat, particularly around the middle, so-called visceral fat, tend to have more of these triglyceride-rich VLDL and have these smaller LDL particles. Patients who are predisposed to diabetes have these same abnormalities. And this is really a highly prevalent trait. It's probably the most prevalent form of lipid disorder found currently in patients who are at risk for heart disease, even more than high LDL cholesterol. And so we use other tests to identify patients who have this particular profile. We can actually measure small LDL. And in my practice, and I think now increasingly recognized general, that provides a more specific measurement of heart disease risk than does the standard LDL cholesterol measurement. And I'll just mention that my work has also involved the development of methodologies that have been applied in the clinic and in fact are used now by clinical laboratories that sort of transmitted our expertise in the lab to clinical laboratories that offer this more specialized testing. And so detecting not just the LDL cholesterol, but the forms of LDL, and particularly the small LDL particles, has proved to be particularly useful in identifying patients at an early stage. We certainly want to look for this trait before clinical coronary disease develops. Unfortunately, we know how to deal with it, both with the diet and with medication. We'll talk about that. There's another player in this axis, and that's HDL, or high-density lipoprotein. And so part of this profile that we just talked about, what we call it atherogenic dyslipidemia, high levels of triglyceride-rich VLDL and remnants, increased levels of small LDL, are also associated with low HDL. Low HDL cholesterol is a very well-established risk factor for heart disease. So it's this entire constellation of traits that is a key component of something we call metabolic syndrome, which is a broader category of heart disease risk factors that can also include tendency towards diabetes, tendency towards high blood pressure. But that's the most dangerous mix of all is when you have all of these factors in combination. That's where heart disease risk can really multiply. There's one other form of particle blood that deserves attention, and that's called lipoprotein little a, or LP small a, which is a form of LDL that carries an additional protein that renders it more susceptible both to oxidation and damaging the arteries through that mechanism, but also promoting blood clots. And so that's actually a genetic factor. It's highly strongly genetically influenced and elevated levels of Lp(a) that are associated with heart disease risk are really quite common in the population. They're not routinely measured currently, but that landscape is changing. One of the reasons that it's been kind of overlooked is that because of its strong genetic determinants, it's very difficult to treat. But we're now developing new therapies that can attack the Lp(a), so we're starting to pay more attention to that. So all of these factors in varying combinations are things that we want to pay attention to as we evaluate heart disease risk.
So, Ronald, a follow-up question. You mentioned LDL, you mentioned HDL, you mentioned LP little a. From what I read and understood, there is another factor called ApoB, and it sounds like it's also playing a pretty important role in atherosclerosis. And it sounds
Right.
like somehow both, as you said, the LP little a and ApoB are not tested routinely via physicians. So can you a bit elaborate on ApoB and also explain why LP little a and ApoB are not tested by
Sure.
normal physicians?
Sure. So ApoB, as I mentioned a moment ago, ApoB is the major structural component of LDL. It actually starts in VLDL. So VLDL and VLDL remnants and LDL particles and Lp(a) all have ApoB as their major protein components. The ApoB is kind of a structural platform on which these particles are formed. And so it's a very large protein. And there's one molecule of ApoB for each of these lipoprotein particles. So if one measures ApoB in the blood, and that can be done now with a very inexpensive and standardized assay, one gets a global measure of all of these particles. You're measuring the numbers of particles. The level of ApoB gives you a measure of the total number of VLDL, VLDL remnants, all forms of LDL and Lp(a). Collectively, ApoB is an index of the total concentration of all of these particles. So it's not specific for any one of these, but it has achieved, I think, a lot of attention, and I think properly so, because it's a more powerful measure of heart disease risk. In many cases, standard lipid measurements, LDL cholesterol, does not necessarily reflect the numbers of particles. And since all of these particles can contribute to varying degrees to atherosclerosis and plaque formation, there's a really strong argument that has been made for measuring ApoB in a standardized way. The reason and I can't fully explain the reason it hasn't become part of the current guidelines. It is actually a part of the guidelines in Canada, for instance. There is a cholesterol treatment guideline that incorporates ApoB as one of the screening tests. It hasn't reached that level of acceptance yet in the U.S., and it's partly because the guidelines that exist for cholesterol management are heavily focused on LDL cholesterol. And that, I think, is a few steps behind where the field should be. I think there's a strong argument that ApoB can be a better measure. But I'll mention that it's a global measurement, so it doesn't tell you how much Lp(a), it doesn't tell you how much of the small LDL specifically, but it's a step in that direction. That is, it's a more meaningful estimate of this overall impact of these particles and the LDL cholesterol. And there are, as I mentioned, we can measure specifically the components of that. So I've very much been a proponent of more detailed measurements that doesn't look at the total, although that is ApoB measurements reflecting the total could be useful, but I think it's even more meaningful to drill down to measure the specific forms of these particles, the LDL particles, and the Lp(a). Now, regarding LPA measurement, I also mentioned briefly that this is strongly genetically determined, and current treatments that are available for cholesterol lowering, for the most part, have a very modest or no effect on Lp(a) levels. Statins, for example, the most widely used cholesterol lowering treatment, does not lower Lp(a). And so it's a genetic factor that we are looking to try to find better ways of treating. But one reason it hasn't been measured is that we currently don't advocate and don't even have effective treatments for lowering the Lp(a). The argument for measuring LPA, however, which I strongly advocate, is to get a picture of the overall risk. Because it's a strong association with risk, it's helpful to know if someone has a genetic factor that raises their Lp(a), because that would argue for paying attention to the overall risk, trying to reduce all the factors that we can improve to kind of counteract that impact of high Lp(a). The other reason for measuring it is particularly when there's families who have a strong family history of heart disease, we often find elevated levels of LPA in people who don't know they're at risk. And first-degree relatives, for example, a patient with a heart attack can be screened for Lp(a), and we often find that they are harboring this from childhood, because this is a genetic trait that starts off at birth. And so when it's exposed to high Lp(a) over many years, but even in younger individuals, there can be developing signs of heart disease below the surface. It's one of the many reasons we call heart disease and cholesterol problems in particular silent killers, because people have these traits and they're developing the atherosclerosis plaque formation, but aren't aware of having anything going on until they start developing symptoms. And by that time, it becomes much more challenging to reverse that process. So measuring Lp(a), I think, does have a role both for screening for risk and particularly when there's a strong family history of heart disease.
So a follow-up question about Lp(a). I think that that's a very important subject and also very exciting, maybe for the positive or maybe for the negative. The first one is, what is the prevalence of having a high risk of Lp(a)? And the second
Okay.
one, is there a genetic test that you can do that, or do you really need to test it in the lab?
Okay, so there are probably 50 different genetic variants that can increase Lp(a). They're all connected to the same gene, but there's just an amazing variety of different genetic types. There's some that are more common, some that are more rare. And so that becomes of interest from a research standpoint, and there may be some differences in the form of LPA depending on which genes you're having, which genes that you're harboring. But that heterogeneity makes it rather impractical to use genetic testing. But fortunately, at least for risk assessment, measuring Lp(a) in blood is now pretty well standardized. There was a period of time where, because people weren't paying as much attention to Lp(a), the methodology was sort of left aside, and there was a lot of variability in different labs measuring Lp(a) using different techniques. We're past that now for the most part. Major labs in this country can now measure Lp(a) in the blood, and that sort of bypasses the need to do the genetic testing. Now, with regard to your question about the prevalence of elevated Lp(a), like LDL levels, small LDL, whatever you choose to measure in the cholesterol sphere, there is a continuum of risk. There's no obvious break points. So, for example, people who have higher levels of LDL are going to get higher risk. If we lower the LDL, we can lower risk proportionately. That's true for Lp(a) as well. And the best data that are available give a rather shocking figure, and that is that levels of LPA associated with significant increase in risk are present in about one third of the population. Very, very prevalent to have high levels of LPA. And so it's a sleeping kind of bad guy that's out there that most people who are affected have no idea that they have this. Very, very prevalent.
Looks like it's a low-hanging fruit to improve the quality of life of the population.
Well, if one is aware of it, one can take measures to reduce one's overall risk. And as I mentioned, there's a couple of very exciting treatments that work directly on the gene itself that are hopefully going to be approved in the next few years for managing patients who have heart disease and who have high Lp(a). This looks like a very exciting horizon for our ability to reduce heart disease risk.
Yeah, definitely. And maybe we, for those that don't know, at the beginning of the show, cardiovascular disease is the #1 cause of death in most cultures for people. Individuals that have diabetes don't end up passing from diabetes. They end up passing away from cardiovascular disease.
Right.
And I think this LPA is interesting because when you look at some people, you think that they look healthy, but really how someone looks doesn't necessarily have an influence so much on
Right.
what's really going on under
Right.
the hood, so to speak, in their
Right.
body.
Right. Well, that's true also, even more broadly for atherogenic dyslipidemia, the other lipid traits that I was talking about. All of these traits are common, and yes, they contribute to huge prevalence of cardiovascular disease, not just diabetes, but kidney disease, liver disease, fatty liver disease, which is also becoming a common abnormality. All of these traits can kill people because they predispose to heart attacks. This is really the common pathway for many factors that can impact these risk profiles. And
I
it's
think a
becoming the
good
leading
tool for
cause
so
of
many
death.
people to know.
Yeah. It's becoming the leading cause of death globally, actually. Many cultures that have adopted Western lifestyles, cultures, for example, that traditionally overall risk that would be considered quite low in Asia, for example, or requiring Western-style habits, we're seeing increased risk of heart disease in those cultures as well.
And that's a good pivot to how your research really extensively studies the impact of dietary patterns on health. So how would you describe a heart-healthy dietary pattern?
Right. Well, again, this is something that I've been deeply involved with, and it can be either a very simple story, which I think for most people is, or a little bit more complex, depending on particular metabolic traits that people carry. Overall, dietary patterns that are rich in plant-based foods, fruits, vegetables, and fruits, whole grain products, products that are not about processing of the grain. Fish, dairy, interestingly, is another part of the diet associated with lower heart disease risk profiles. So that really translates in kind of a simple way to what's been called the Mediterranean dietary pattern. And studies of this Mediterranean dietary pattern, both in Mediterranean countries, but elsewhere as well, that have shown that patterns that include these components are associated with lower heart disease risk than standard diets that are rich in processed foods, processed grains, sugars, etc. Now, what's been a little bit more contentious is the role of saturated fat. Saturated fat is the type of fat found in animal products and tropical oils as well. It's a form of fat that's consumed in these foods that can raise LDL levels, and there's been a concern regarding that effect and its relationship to heart disease risk. What we have shown, and this has been shown by others as well, is that kind of non-intuitively, high levels of saturated fat raise the cholesterol, but primarily in these larger LDL particles that I mentioned. So even though the cholesterol level has gone up, the saturated fat itself primarily affects these larger LDL, which are not nearly as strongly associated with heart disease risk as are the small LDL. The small LDL, arising from this VLDL triglyceride pathway, are heavily influenced by carbohydrates in the diet. And that's where highly processed starches, particularly added sugars, have a very detrimental role. And so when we see patients who have this profile, their LDL cholesterol may not be elevated. These particles that we're talking about may not be carrying a lot of cholesterol, but they are damaging. We know they are based on their properties and association risk. And those patients who have elevations in these small LDL benefit really from two dietary approaches. One is weight loss, because as I mentioned, excess body fat around the middle should be managed to try to reduce levels of these particles. But here's where carbohydrates come into play. And so the focus on our dietary guidelines on saturated fat has for many years sort of overlooked the important role of carbohydrates. And people who have tried to limit saturated fat by reducing their fat intake often make the mistake, and this was encouraged by earlier dietary guidelines, of substituting carbohydrates. And when you make that switch from fat to carbohydrates, you can actually expose patients who are at risk because of the lipid traits that I just mentioned. The triglyceride small LDL axis can be amplified when there's too much carbohydrate. So patients that I see, and really a lot of people out there who are not aware of their heart disease risk, may be carrying these lipid traits that would benefit from reduced carbohydrates. So getting back to the Mediterranean diet, that diet is not, it should not be high in processed carbohydrates. So that overall dietary pattern that I started off with, for many people, for most people, can really involve a healthy balance of fat and healthy carbohydrates, avoiding the types of carbohydrates that can increase this atherogenic dyslipidemia trait. But people that are affected, who either have heart disease or who have the high risk profile, need to be even more careful about carbohydrates. So there are patients that I deal with, and there's guidelines that are starting to emerge, for example, even in the diabetes world, that emphasize really fairly significant limitation of carbohydrates below levels that are currently recommended in the diet. And these very low carbohydrate diets can be beneficial.
In the 90s, when the low fat, any type of fat is bad methodology for managing heart disease came out, now years after that, we can see how much more damaging that swap to just take out fat and replace it with all types of sugars really was.
When I first became involved with the Heart Association guidelines, a couple of decades ago, I inherited this mantra. The mantra was low fat. And the food industry was very cooperative by providing, and they still do, products that they advertise as being low in fat, but don't necessarily mention the fact that they are higher in carbohydrates and sugars. And that was a big mistake, as you say. That trend, fortunately, now has been reversed. I think there's much more attention being paid to a more balanced approach, although there's still a fair amount of resistance to limiting carbohydrates further. The guidelines still allow a fair amount of carbohydrates in the diet. That can still be a problem for many individuals.
And something else you mentioned was fish having a pretty big role. In your research, you also certainly described those cardioprotective mechanisms of fish or marine omega-3s. Can you describe that for us?
Yeah, well, that's a bit of a complicated topic, I'm afraid, because there's good epidemiological evidence that consuming fatty fish, salmon, mackerel, certain forms of tuna, which are enriched in what's called omega-3 fatty acids, a type of unsaturated fat that has helpful qualities. The intake of those fish has been associated with reduced heart disease risk. And so it's one strong reason that we encourage this part of the overall diet. But it's unclear still whether the oils from those fish in and of themselves are beneficial. There have been many studies using fish oil supplements as a way of trying to capture the benefits of fatty fish intake in a pill form or capsule form. And there's been some recent studies that have failed to show benefit of fish oils, although there is one form of fish oil, a very specific form of fish oil that's a prescription form that may have captured some of those properties. But the kind of fish oil that you get over the counter that's been studied fairly extensively has not been clearly associated with heart disease risk. High levels of those capsules can be used to lower triglyceride interest. There are some patients out there who have very extreme triglyceride elevations that put them at risk not just for heart attacks and stroke, but also for pancreatitis, actually, which is a pretty serious condition associated with very high triglyceride levels. And the fish oil capsules that are out there can lower triglyceride levels, but that doesn't always translate into reduced heart disease risk. So and this is the case for the dietary recommendations in general, we really should be focusing on foods rather than trying to dissect out individual components. That leads to making extrapolations and inferences about this or that supplement that really don't reflect the properties of the overall food in which they're consumed. So, for example, in the case of saturated fat, even though that remains a big focus of our guidelines, there's saturated fat that can be found in dairy products and saturated fat that is found in meat products, for example. It's been shown that dairy foods themselves, that is the whole food, and particularly fermented dairy products such as yogurts and cheeses, have been shown to have cardiometabolic benefits that are related to the food itself. And so trying to focus on a particular component, i.e. their saturated fat content, kind of misses the importance of the overall food that can have effects that really are not measurable, except that they, in standard terms, but they are associated with improvement in cardiometabolic profile. So I think a big message that I've been trying to advocate, and this relates to the work we do in our educational activities, is to move away from breaking down specific components of the diet and looking at overall food and dietary patterns as the best way to accomplish what we're trying to achieve with dietary guidance.
So in this line, Ashley and myself, actually, the Insight Tracker, we published a paper about the effect of a personalized nutrition platform on those blood biomarkers. And what we have seen that for LDL cholesterol, we've seen that the subpopulation that consume yogurt indeed decreased their level of LDL cholesterol pretty significantly. So it's fit very well to the point that you're mentioning, which is great.
Yeah.
My question is, yes, nutrition can help, but sometimes it can't. And I can give you myself as an example. I was trying everything that I could to decrease my LDL cholesterol, all the supplement, a lot of different kind of food, and I failed. So then I went into the statin. And I assume and I know that a high percentage of the population at the end of the day will go into statin. So my question to you, Ronald, is what age do you recommend to do it? Is it any age is too early or is it too late? And also, is it a specific level of LDL cholesterol that is the right one to start taking statin?
Okay, well, good question. So our current approach to advocating the use of statins or to recommending statin use is really based on overall cardiovascular disease risk, looking at the entire set of factors we talked about earlier on. There's ways of calculating risk using various formulas. And for people that are found to be at very high risk based on those formulas, which include cholesterol measurements, but also other factors such as blood pressure, diabetes, age, sex, those the patients at highest risk who continue to be at high risk despite following a healthful diet are candidates for statin almost at any age. Certainly, we tend to find the higher risk individuals as we get older in life. But as I mentioned, we look at genetics as well. And so there's a very important group of individuals who inherit genes that can raise their LDL levels dramatically. And so when LDL levels are found to be in that range, there's a genetic component to that. It's called familial hypercholesterolemia, very common trait, maybe as much as 1 in 200 individuals, which doesn't sound common, but as a genetic trait, it's actually quite common. So there's millions of people affected with this genetic disorder, which starts in childhood. And so we're starting to advocate, based on studies of safety and efficacy, use of statins in those individuals, younger ages, even in adolescence. We have to be careful, of course, with women who are planning to get pregnant. We don't want to use statins in that situation. But otherwise, these younger individuals with very high levels of LDL should be treated early on. But for the rest of the population, as I mentioned, we look at the overall risk profile and introduce statins when that risk becomes unacceptably high. But we don't necessarily use a number anymore. We used to have LDL cholesterol levels that we considered high or moderately elevated or optimal. Those levels are out there. We get those numbers. For example, when people have LDL levels greater than 190, compared with, let's say, the average level of 100 to 110, that's the group of people who many of whom have genetic hypercholesterolemia, familial hypercholesterolemia. That level is too high. And then we try to lower it as much as we safely can. We don't necessarily have a target for all patients. However, there is an argument that's been made, and it's been introduced into our guidelines, that for patients who have already had heart disease, who have already had evidence of cardiovascular problems, heart attack or stroke, or even disease of the arteries, the legs, for example, that these are all places where people can develop signs of atherosclerosis. But if they have something that's clinically significant, particularly if they've had a heart attack, we aim for targets that are really quite low. So we do have targets there, less than 70 milligrams per deciliter, or even less than that, is what we try to achieve in those patients if we can with diet and medication. So between 70 and 190, there's a whole range of levels. People can have high heart disease risk as a continuum. As I mentioned, LDL levels are associated with risk in a continuous manner. So any degree of LDL lowering can be considered a therapeutic goal in patients who have high heart disease risk, even in that middle zone. But if we're to use a number, the number that I would use for, let's say, the general estimate of risk, it's not a perfect cut point by any means, because LDL cholesterol itself, as I mentioned, is not necessarily the best single measurement of risk. But when looks at LDL cholesterol levels less than 100 would be considered, I think, the optimal level for many patients, just in the general population.
And speaking about statins, so what are the side effects of this drug?
Well, so in addition to my work with lipoproteins and nutrition, for the past couple of decades, I've been very deeply involved in research on statins. So I could tell you a lot about that. I'll try to keep it at the level which is appropriate for clinical purposes. Statins are clearly effective in lowering LDL and reducing the risk of heart disease. However, if one looks at the benefits, it's not going to protect everyone. The best clinical trials with the most powerful statins can achieve a reduction in LDL in heart disease risk of perhaps 50% associated with a degree of LDL reduction. It's also about 50%. That's a lot. So you can really cut the risk in half if you really can manage the LDL effectively. But that leaves half the population or more, despite taking statins, will be at risk for heart disease. So we're really interested in identifying factors that may contribute to the failure of statins to be a benefit. And as I mentioned earlier, the Lp(a) is one of those factors because it doesn't respond to statins. The small LDL does not respond to statins. So the people who are taking statins who are not going to get as much benefit as one would hope, but considering all the other options, it represents by far and away the most effective tool we have available. That kind of reduction, even though it's not complete, is still substantial. Having said that, there are concerns about possibility of side effects of statins, which can be significant. The most common of which is muscle pain and muscle aching, called myopathy, muscle soreness, weakness, can occur, depending on what report one is reading, anywhere from several percent up to maybe as many as 20% of patients taking statins will develop muscle symptoms. And in my clinical work, but these are many of the patients I tend to see, patients who are not able to tolerate statins. Sometimes, because there's half a dozen forms of statins available, one can change statins from one form to another, and that can sometimes reduce the muscle symptoms. But there are some patients who are intolerant to any statins, and there we have other options that are available to us that can be effective in LDL lowering that do not have side effects, fortunately. There are other side effects that people experience that can be kind of very vague. Sometimes people feel that they're getting a little bit fatigued, or they have some fuzziness that we're thinking. We don't know for sure that those are statin related, but one has to take these side effects seriously, and that's where I think under medical supervision really should try to explore ways of reducing the likelihood of those side effects by manipulating the treatments appropriately. There's been a lot of scares, particularly on the internet, that have steered people away from statins. There's a lot of literature that really makes it sound like statins are the most dangerous thing in the world to take. And I see patients like that as well who have been concerned that even though they're at high heart disease risk, they'd rather not take statins because of their concerns about whatever side effects might be result from statin use. I might mention that there's another test that we can use clinically that can sometimes help make the decision as to whether statins are needed, and that's a form of X-ray. It's called the coronary CT scan. It's a very brief exposure to a little bit of radiation, but you develop an image of the amount of plaque in the coronary arteries by measuring the calcium content of the coronary circulation. That's called the coronary artery calcium score. And so this has now become more commonly used to help discriminate those patients who may have underlying heart disease, but who may be reluctant to take statins. And if we find that there is a significant amount of coronary calcium in those patients, it sometimes helps make a decision to move ahead, particularly if the lipid levels are borderline or if they're not sure if they're at heart disease risk. A high calcium score would be a direct measurement of something that requires attention. Conversely, and there's patients like this as well who have sort of highish LDL levels but are otherwise healthy. They may have good levels of HDL. They may be exercising lean, and they come to see me and other physicians saying, well, what I read and what my doctor tells me is because of my cholesterol, I should be taking a statin. Do I really need to take a statin? And in many of those patients, when we analyze the coronary artery calcium, we find that there's no calcium at all. The score is 0. In those patients, we can be quite confident that they are not developing a significant amount of plaque. And we can reassure them that statins may not be necessary. So that's another test that we can use to help discriminate risk. There's one other test in that same category, not an X-ray, but a blood test, which is a measure of inflammation. Because inflammation is another component of heart disease. I mentioned, of course, the cholesterol and the plaque buildup. But once there's a significant plaque buildup, and if there's oxidation and other changes in the artery that make it more likely to lead to a heart attack, we have inflammation as being an important component of that process. And there's a test called CRP, C-reactive protein, that is a very good measure of the overall inflammatory milieu. That is, how much inflammation is going on that might be contributing to heart disease risk. And when there is elevated CRP levels, people who may have borderline lipid levels, that would be another indication that they would be candidates for treatment. Fortunately, statins, in addition to lowering cholesterol levels, have an additional effect on inflammation. They lower CRP, they can be anti-inflammatory, and there's good reason to believe that the benefit that statins do have in heart disease risk can be attributed both to the lipid lowering effect as well as the anti-inflammatory. We don't have many other treatments like that. Statins are kind of unique in that regard.
Yeah, so to put all the information that you gave us, which is amazing, in my words, it sounds like a statin decreased the level of LDL cholesterol by up to 50%. It's also decreased the level of CRP or hsCRP, which is an inflammation marker. And it sounds like the side effect of statin are pretty mild. It's
for most patients. For most patients. Yeah. I should say there's a caveat there because muscle symptoms can progress, and so one has to be very alert if there's a statin-related muscle problem to do something about it so that it doesn't progress. Because if it does, it can cause much more severe muscle damage and even fatal condition. So, and that's only present in 1 in 10,000 people. So it's not something we have to worry about generally, but one has to be careful to minimize that effect.
Yeah, and obviously everyone that want to use statin should ask his physician. It's under a physician control. Don't take statin just because our discussion for sure.
Well, fortunately, it's still a prescription item. There is a non-prescription form that's called red rice yeast. It's a supplement that I discourage the use of. It's a mixture of statins that can be obtained from a fungus, red rice yeast. It's used as a dye, actually. China, but it can lower cholesterol levels, but it's not particularly well regulated. And if you're going to take a statin, you should really use not on your own, as you say, but use a prescription form with medical guidance.
I feel like we get questions a lot about red rice yeast, and our response is, if you're willing to do side effects, take the thing that you know is going to work. Take the statin. But the internet, really good at marketing things.
I know.
Okay.
Red rice yeast is not particularly potent either, and it's not nearly as potent as the best statin. So you're just dipping your toe in the water, and you don't know, what the temperature is going to be. You put it in, you should get burned.
And how about stress or cortisol? Especially over the past few years for all of us, how does that have an impact on cardiovascular disease risk?
Well, there's plenty of studies that high stress situations can promote both metabolic changes through renal effects in particular, and sometimes more acute effects, obviously, when there's under acute stress that can, through various mechanisms, trigger dangerous heart problems. So stress is a factor for sure. wish we could do more about it. It's very hard to avoid some of the stressful conditions we're dealing with these days, but it is a factor of it's contributing to the overall risk.
Definitely contributes to that overall lifestyle, not just taking a statin, but also controlling so much else of what you can control. Okay, final question that we ask all of our guests is if there's one decision that you make every day based on nutrition or everything that you know about heart disease, cardiovascular disease, that you can share as a tip for our listeners?
Okay, when you say one, if I can make that,
okay,
if I can make that a broad one, because I really think the most important single arena for prevention is a healthful diet. Healthy dietary pattern. I think that really transcends everything. It's really the basis for everything we're doing to try to reduce heart disease risk, and that involves, this is sort of a related issue, is avoiding excess adiposity. Because I think that's really a culprit that is really causing problems in multiple ways that aggravate heart disease risk. And certainly the rising incidence of obesity and excess adiposity is something that can be avoided if one starts early in life. And currently affiliated with the Department of Pediatrics. I'm an adult doctor, but my academic appointment is in pediatrics, and we're starting to work more closely in the pediatric age group to try to practice prevention through healthful diets, to try to avoid excess body. The best way to do that is to start young. So for us adults, for those of us who have gained weight in their middle years, which is very common, I think that would be part of my single recommendation, is to try to avoid that.
Gotcha. Well, thank you so much for your time, for taking the time to speak with us today. It was amazing to get to learn from you, and I'm excited.
Okay, well, it's great to have this conversation. It's always an area that I have a deep interest in, and I'm glad to know we're going to have some opportunity to explore this with those who are attending this session.
Thank you so much. It was a pleasure.
Okay, thank you.
And we look forward to exploring the research in the field of longevity each month with you and the leading scientist. For more info, please go to www.insidetracker.com/podcast.
Thanks for listening to Longevity by Design. Please subscribe to this podcast on Apple, Spotify, or YouTube. Longevity by Design is powered by Inside Tracker, a personalized health optimization platform that helps people improve their lives by improving their bodies from the inside out using personalized, science-backed recommendations for nutrition, supplements, and lifestyle changes. To learn more, visit insidetracker.com/podcast.